Obstetric and Gynecological Society, and she has consented to be present here today and speaking all on the overview. We have wonderful speakers lined up with us, and I'm sure you will be having all the luminaries who are going to shed the light of how to go ahead with the violence against women, the survivor, how to face the violence, especially in pregnancy and women. And there are many. I can go through the statistics, but I leave it to the faculty members who are going to be there today. And even just before starting also, I got so many phone calls. What is this Dheera program? There are residents which are calling. They want to get online registered. They want to get training, because we get so many women, so many girls, even adolescent girls. I am situated at Sion Hospital, which is in between the Eastern and the Western Express Highway, and catering to the largest slum area of Asia. Thank you, Madhuri Madam, for joining us. I am just giving you the overview. For Madam is there at the helm of affairs. Wonderful year of 1.5 year of Shanta Kumari Madam, and there are so many things. I think mental support. Parikshit, you have taken a wonderful topic that is still a neglected one from the point of view of gynecologist, and that topic is well taken care of you. I know courtesy your better half probably will be putting some views in that, and I'm sure both of you are going to be there for us. Then we have Amay and Komal going to chair the session from 3 to 4 p.m. And we have Sujata Darvi, very dynamic clinical secretary of MOGS all the time. She's very, very busy. I'm sure she will be also training and talking about challenging issues. Yes, there are many challenging issues which we come across, and self-care in dealing. Then we have Kiran Mai. Kiran Mai is just the newly appointed, I think, is she there now? Yes, she's a newly appointed, going to come on 22nd as the violence against women. This is a new committee which has been started, and I think Kiran Mai, you are already started, rocking, and you have got a lot of responsibilities being there, and I'm sure you will do a wonderful job in the next coming year of Dr. Rishikesh Pai, who is going to take over in 22nd of October. That's a auspicious day of Dhanteras of Diwali. And of course, then we have Madhuri Mendre, our young and dynamic member, who is there with us for such a long time, and she's going to talk about how to approach on sexual violence. And then the last but not the least, the icing on the cake is Anita Sabarwal from Delhi. She is going to be talking on something examination. That's a very important topic, and we have now one-stop clinic. At one given time, there are all the departments are going to be there at one place, so that the patient doesn't have to go and wander from forensic department to pathology department to swab, and then again examination, and then again undergoing some surgery or something. So all these things are going to be taken care of without much ado. I want to finish this program by 4 p.m. and I'm sure I have given justice for the President's message, and we look forward to a wonderful session and a Q&A session, and I'm sure Parikshit and Pratik are going to rock this program. After many days, rather months, I have come today online, and I'm really happy, and I'm recollecting those days of COVID where we used to do every second day, third day programs. So I was little jittery, to start the program and then to talk and how to go about, but I'm still well versed. I can still do it. Thank you so much for giving me this opportunity, and thank you, and we will get back soon. Thank you all. Bye.
Thank you very much, Dr. Niranjan Savan, sir, for gracing the occasion. I would like to invite my co-convener, Dr. Parikshit Dan, to speak a few words and then introduce our first speaker of the day, Dr. Madhuri. Over to you, Parikshit.
Thank you, Pratik, and it's a pleasure to be with all of you today. Already much has been spoken in terms of the preamble for today's event. This is really the flagship program that Foxy has rolled out this year, and Mumbai Society is glad that we can host one of the training sessions and workshops today. So thank you everyone for joining, and let's get on with the show.
Parikshit, would you like to introduce Dr. Madhuri Patel?
Sure. I don't have the formal slide, but do you have it, Pratik?
No,
just
don't worry, Parikshit. You can say whatever you want to say about me. Apart from Secretary General.
no, that is really the jewel. That's the jewel. That's the crown, which is I'm sure very very prestigious position which Dr. Patel has. She's been a teacher, a professor of obstetrics and gynecology in Mumbai since about 35 years and very richly experienced. Currently practicing in private and at the Wadia Maternity Hospital. So welcome, ma'am, and please do address us.
Thank you, Parikshit, for your kind and generous word. He is my treasurer. So he cannot say anything against me. He has to say yes, yes every time. So that's why he was confused all the time. Okay, what is to be introduced, because we could not display my slide, but that is okay. So Parikshit, thank you for your generous and warm introduction. And Pratik, I must also thank you that he was after me all the time. Now also, he was after me. I said, I am filling up those 20 questions, then only I can join you, So sorry for joining little late. And Niranjan, I miss your things, little bit, but you are always excellent. And you are the person, digital person, I must say. Not only physical, events, but also he has done so much of work during COVID, every day, every alternate day, he has kept webinar, and he is not only known in emojis, but nationally as well as internationally. Many people know him, when I went for the Suffolk conference, when I've gone to the other conferences, Niranjan is very, very popular amongst all the other international faculty also. So Niranjan, I really appreciate you. And, you are doing excellent work as far as MOGS is concerned, and as far as my joint treasurer concerned, he's also doing excellent work. So I really appreciate you. And Dr. Ramni Devi, I had a very good time to work with her when she was the vice president, and now also I'm working with her. Kiran Mai also, I had an opportunity to work with Kiran Mai when we were doing a panel discussion at Hyderabad conference. And you believe me, I kept awake her up to 3 o'clock midnight. And she next day she was sleeping at the time of panel discussion. She was my co-moderator. So she felt, okay, madam is really, giving me this violence, violence against women. It is not done only by the men, but it is also done by the women. So, Kiran, do you consider it? Then I'm really,
Ma'am, it was a great learning experience. I'll remember it for my, how much patience and diligence and hard work you put in.
So, and Mandakini Meghe, madam has also joined, very good friend of mine, and we have done our MD together. Madam had come from the health, system, and I was as a PG student, and we appear for the exam, and we are very good friends since last 35 years. And of course, Mansi, our young Shriman, Deepika, and Beena, and all my dear friends, these are the young budding, people who are doing excellent work. And my time will start when I start presenting, right? So my families have gone over here, and I really appreciate, Dr. Shanta Kumari bringing on this Dheera program, and it is really doing excellent. This is awareness, sensitization. She is doing a school program also, and that is more important. The children have to learn that what is going wrong in the school, not only school, but also in the family. So they are the one, they always tell. See, whenever we ask our patient, they will never answer. They will hide something. But if you ask a child what is happening, when they accompany them, they will come out with, correct answer. So they have to learn right from that. And I'm really happy that, Dr. Shanta Kumari has, come out with a very good, initiative. And I congratulate her and her team. I would like to share my screen with this.
Dr. Madhuri ma'am, I met you just day before and you forgot me.
Oh, Anita, I thought I already talked about you, Anita. I'm really, so sorry. I thought I really talked about you, Sorry, Anita. Twice I will repeat, okay? Anita and me had a...
Just joking. I thought I have to tell you.
Anita and myself were at Faridabad just 2 days back, and we had a very good time. And she is a woman activist, okay? And if you see her Facebook and all the, what happened in my WhatsApp, no? Our system automatically, downloaded in my mobile. So I see her so many activities. She is with the activities as a, greenery. She believes in greenery also. There also she is active. And Anita, I'm really sorry I missed you out, but good you told me, you reminded me, and I'm really thankful for that. So with this, I start with my talk on violence against women and overview. And Kiran Mai, Vidya, and Dr. Ajay Bhargav, they are really, here to help this program. And of course, this is, as I mentioned, this is initiative by Dr. Shanta Kumari. And Anita, like, how I forward you, Dr. Shanta Kumari has also forwarded me to put my name as a Secretary General. So you are excused, I am also excused, okay?
Yeah. Not
Okay.
at all.
So on behalf of Dr. Shanta Kumari and team, a sincere thank you to all those who helped collaborate on this project. And Team Dheera, the PPT was contributed by Dr. Shanta Kumari, Kiran Mai, Dr. Ajay Bhagat, and Dr. Vindhya, Dr. Ramni Devi, Dr. Rakhi, Dr. Deepa, and Anita again, Dr. Jyoti, Dr. Rohan, Krishnendu Gupta, and Dr. Aruna Suman. So we are really thankful to them. So if you look at before we start the talk, I want all the participants who have joined today, they have to put in the chat box what form of GBV are experienced in women and girls. Secondly, where can you women and girls experience GBV? Which age group may experience GBV? So these are the very common questions. Whatever you experience, I would like to ask our participant to please put on the chat box. So at the end of this session, this program, we will know the postage, questionnaire, okay, how much, we are aware and how much we are sensitized. So the violence against women means any act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women, including threats of such acts, coercion, or arbitrarily deprivation of the liberty, whether occurring in public or private life. So this is the real definition which we have to understand, that it is a physical, sexual, and psychological harm or suffering of the women. So now let's see that violence against women encompasses, but not be limited. So it is physical, sexual, and psychological life. It can happen in a family. It can happen in the community. And perpetrator should not only be, the state is not responsible only to perpetrator, that they should, only state should take action, but we are also here at the, family level, community level, and we should also, condemn this, and we have to take some action in whatever form we feel appropriate, but don't go to the physical, action. So what are the type of violence? Physical violence in form of kicking, biting, slapping, beating, strangling. Psychological violence are preventing a woman from seeing family and friends, belittlement or humiliation, economical restriction, violence or strength against cherished objects, and other form of controlling behavior. Sexual violence are in the form of forced sex using physical force, threats, intimidation, and remember, this is applied to the married women also. Forced participation in degrading sexual act, denial of the right to use contraceptives or measures to protect against sexually transmitted diseases. So it is said that, many of our women, they are concerned about their family. They're concerned about their, brother, husband, uncle, and they don't report it. And it is, sometimes we take it as an accident. And when they get admitted in the hospital, we all have seen many times that they say they had an accidental birth, they had an accidental fall, accidental injury, and they don't come out because they want to protect their family member. And in that, when they are protecting, many of them have lost the life with these injuries. So 30% of the globally, it is experiencing this violence against women, violence against by their partner. So can you see this partner, 30% has been reported. I don't know how much, if you go into it, how much it will be. So it was calculated by WHO regional wise in 2010, the prevalence rates of intimate partner violence by WHO regional 2010. So 23, it doesn't depend upon whether woman is from low, socioeconomic status, middle income group or high income group. It has been reported in 23.2% in a high income group also. So it is not concerned with what socioeconomic status you are coming. WHO reported 29.8 in Americans. Then it was reported as 25.4% in European region, 37% in Eastern Mediterranean region, 37.7% Southeast Asia region, and 24.6% Western Pacific region, and 36.6% African region. So these are the region where they have reported. How much they are, happening, we really don't know. So now it is said that gender-based violence is underreported. This is tip of the iceberg. DHA survey data from 24 countries collected between 2004 and 2011. 40% of women experienced GBV previously disclosed to someone, but only 7% reported to a formal source. Regional variation is there, and in India it is only 2% reported, and East Asia 14%, in Latin American and Caribbean. So see how much reporting is done, because all the women, of course, with the education, with the women empowerment, now many girls and women are coming out with this reporting, but still it is very, very low. So if you look at the cycle violence, the cycle of the abuse, that it starts right from pre-birth. Sex selection, abortion, effect of battering on pregnancy and childbirth, then infancy, female infanticide, physical and sexual, psychological abuse. Then as far as the girlhood is concerned, child marriage, female genital mutilation, physical, sexual and psychological abuse, incest, child prostitution, pornography, and adolescent trafficking, honor killing, partner violence, marital rape, dowry abuse, murders, abuse of women with disability, rape, sexual harassment, forced prostitution, and pornography. So these are the different ways. It starts from pre-birth, infancy, girlhood, adolescent, and of course it comes from the women. And these are the different types of you can see. So then forced pregnancy, acid throwing, date rape, economical coerce, sex, incest, sexual abuse in the workplace. These are also important because majority of women, girls are working today, and we have to be taking care of this part also. So 20% of women experience child sexual abuse. 60 million women globally are married before 18 years, and 125 million women in 29 countries in Africa and Middle East experience female genital mutilation. So in 1957, women in Pakistan killed in the name of honor between 2003 and 2007. 11.4 million women trafficked globally. 30% experienced intimate partner violence, and 7% sexually assaulted by someone other than partner. So this is a data where you can know what are the different type of violence against women and what happens after that. So what happens? It can affect the physically in the form of acute physical injury, shock, disease, infection, weight loss gain, regressive behavior, not eating or eating all the time, and chronic physical is disability, chronic pain, GI disorders, eating disorder, sleep disorder, and chronic fatigue. And as far as the reproductive is concerned, it can cause miscarriage, unwanted pregnancy, unsafe abortion, sexually transmitted disease including HIV, menstrual disorder, pregnant complication, and gynecological disorder. So you can see what is the impact of this GBV on the health. It is not only physical, but also in the reproductive system. So it is said, does not only restricted the woman who is a sufferer, who experience the violence, but it also affects the children of women who experience abuse. There were high rates of infant mortality, behavior problems, anxiety, depression, attempted suicide, poor school program, performance, physical injury or health complaint, and experiencing and perpetuating violence as adults. I would like to mention over here the children, they really experience their mother and fathers, how they are behaving, and they really go into all these crises. And as I always tell my patient that please behave properly in front of at least your children. They are growing and they are going to have a problem in their life. So what the effects on families are? Fracture family relationship. If abuse happens in the home, housing instability, co-occurring violence, poor collective health and coping. Effect on the community and society. So it has also effect in the community as well as society. That is the cost of service incurred by victims and families, loss of education and potential development and contribution by child as they become an adult, perpetrator of violence in community, and higher crime rates, burden on safety and justice sector. And I would like to say that India also many, states, many cities, we find this crime and we have so many, incidents in newspaper and what has happened, we all are aware. And, I must say that, our Mumbai city in that manner is quite safe as far as the society and community is concerned. So where and how do violence and HIV/AIDS interact? So there can be direct transmission through sexual violence, type of sexual exposure, presence of other STI and degree of trauma. And there is also indirect transmission through sexual risk-taking. That is, violence is linked to increased risk-taking, multiple partners, non-primary partners. There is indirect transmission through inability to negotiate condom use. Women find it difficult to suggest, or insist on condom use in face or threat of violence. So women sometimes when they insist to use for condom, there may be threat or there may be violence. So one has to take care all these aspects. So these are the chart which is very busy slide, intimate partner violence, which I have already mentioned, that physical trauma can be musculoskeletal, soft tissue, genital trauma and other. Psychological trauma stress can be anxiety, depression, eating disorder, suicidal, substance abuse, alcohol and other drugs, tobacco. Non-communicable disease can occur in form of cardiovascular disease, hypertension, somatoform like irritable bowel, chronic pain, chronic pelvic pain, and fear and control. So these are the things we really, and as far as the perinatal and maternal health are concerned, that will be low birth weight baby, prematurity, and pregnancy load. Sexual and reproductive health can be unwanted pregnancy, abortion, HIV, having other sexual transmitted infection and gynecological problem. So 42% of women who have experienced physical or sexual violence at the hands of a partner have experienced injuries happening due to this. Then mental health is twice as likely to experience depression. Then almost twice as likely to have alcohol use disorders. Then 16% are more likely to have a low birth weight baby. Then twice as likely to have an abortion. 15 times more likely to acquire HIV and 1.45 times more likely to contract syphilis infection, chlamydia or gonorrhea. 38% of all murders of women globally were reported as being committed by their intimate partner. So see, look at the 38%. 4.5 times as likely to attempt suicide. So I would like to, before, I end my talk, I would like to say that yesterday only I had one my patient, from the high socioeconomic status, and she was very much, quiet. As she came for the other problem, gynec problem, and I asked her that what is the problem? Why you are looking so, depressed and all? Then she said, okay, my husband, he is not taking care of me. I'm not happy in my married life. She has got 4 years and 10 years old children. So I said, what is happening? So she said, he doesn't pay attention. He doesn't give me time. He doesn't, do anything, he does, So I said, okay, I heard her. Then I called her for the husband also. And what I realized, that she was under her, shell only. Why? because she never had friends. She is not in good relation with her parents. The husband is looking after, her. He's playing with the children. He's doing everything. But she says that he doesn't give time. He's all the time on mobile. And ultimately, both of them I counseled, and I realized that sometimes the woman also have to have a brain, what you say, occupancy, mind occupancy. And sometimes, we have to see from both the angles. We have to counsel the women, and we have to do the needful. So we are also good counselor when the patient come to us. There's certain things, of course, when there is a violence, you can't prevent it, but certain time you have to counsel and you make the family happy. So after this, I would like to mention the quiz time about the state myths or facts. So the statement is intimate partner violence is more prevalent amongst the women and girls. So what is the answer for that myth? So let us look. Answer about this myth is studies show that the gender-based violence can happen among people of all socio-economical, educational, and racial background. Violence may affect our peers, colleagues, and friends. So this is the answer for this. The another myth or fact statement: majority of sexual violence against women and girls is perpetrated by strangers. So what is the answer of this myth? Studies consistently show that most women who experience sexual violence are abused by people they know. Often the perpetrators are those they trust and love. Globally, women's homicides are 6 times more likely than men's to be committed by an intimate partner. So we have to also worry about when we keep our child with somebody from our family member, maybe brother, maybe father also. We have heard about a father also. And mama, kaka, we have to be also vigilant that what is happening. We trust them, but we all have to be vigilant what is happening with the female child. Then the another is space timing, another is state myth or facts statement. It is safer for a woman to leave a relationship with an abuser than a stay. So what the answer is? Violence often continues and may even increase after a woman leaves her partner. In fact, a woman's risk of being murdered is greatest immediately after separation. So we have to understand this answer. So GBV, gender violence is a serious human rights, health and development issue impacting survivors, their families, and the health and development of entire community. So we have to sensitize, we have to make aware not only our team, that is a obstetrician and gynecologist, but also the community. And we should have more community program for this, and we should make them aware and sensitive, and then only there will be no violence against women. I thank the organizer for giving me this opportunity. And I would like to mention that registration, pre-test and post-test and feedback are very important. Certificate will be awarded to participant on course attendance and submission of registration, pre-test, post-test and feedback. Thank you once again to the organizer for giving me this opportunity.
Thank you, Dr. Madhuri Patel, ma'am, for being here with us, taking time out from your busy schedule and taking the first stop to make us aware that violence against women is all pervasive, especially in the South Asian context. I'd like to hand over to Dr. Mansi Medekar, who is the chairperson for the first session, to introduce our next speaker, please.
So, thank you, Dr. Pratik sir. It was an amazing talk, Dr. Madhuri ma'am. We move on to our next speaker, Dr. Mandakini Meg madam. I think if I just keep on introducing her CV, I will finish off this session only completely. But she is a wonderful human being, a wonderful woman, always smiling, always enthusiastic. She's a mother figure to all of us. Just to give a brief introduction, she's a ICOG Foxy chairperson. And there are lots of good eminent posts that she has held in various organizations as well as in government societies. So, madam, I think I would hand over the mic to you.
Thank you, Mansi. Thank you. Wonderful introduction. Thank you. I'll share immediately I'll share the screen. Let me see where is my presentation. Okay. Okay. So at the outset, I'd like to thank MOGS President, Dr. Niranjan Chauhan, Dr. Pratik Tambe, all all of the, Foxy Secretary General Dr. Madhuri Patel, Dr. Shanta Kumari, our president, for conducting such a beautiful program throughout the year, and now having multiple, training centers, so many trainers. And I think this program is one of its kind, which is going world over. So I congratulate all the Foxy office bearers and even the trainers. And I can see my friend Dr. Ramani Devi also here, and Dr. Anita, Dr. Kiran Mai, and everybody has done a great job of this thing. And I must thank Pratik for organizing such a wonderful program. And everybody knows that, the domestic violence and violence against women is very close to my heart. And I am working on the domestic violence in the AMWI and the Medical Women International also. So Madhuri, thank you for those words. And we are really friends in so many years, and we are together traveling, and all the time we are together. So thank you very much for your company. Now I'm going to talk on a very, very important subject after Madhuri, that is how to approach a women facing a violence. So after this, so important to, to how to deal with the patients who are actually facing the violence. So why do survivors not seek the help? So many times we hear that 100% reporting is not there, hardly 10 to 20% reporting there, and rest of them they keep quiet, whether they are from low economic strata or they are from the higher economic, they keep quiet and they tolerate. And later on I have heard in so many even actresses that after 30 years they are breaking the silence. That one child artist was a Daisy, and now they are coming out with a. So that time maybe the environment was not good and things like that. And now it has become quite women friendly. They can really report and they can come out and there will be no stigma. So I think that is the best thing. So why they do not seek the help? Because victim blaming attitudes of provider. Because so many times, that provider, they do not treat the patient very well, even in the police officials also. The fear of shame and stigma. Fear of no confidentiality, it will become, spread all over the world, and they will, blame her only for her characters and all these things. Inappropriate services or services that are not useful, and prioritize the this thing survivor. The perceived impunity of the perpetrators. So these are the few of the reasons why they do not seek the help, and why there are no 100% reporting of such kind of violences. Now, who can play a role in the survivors and how? As we know, we as a doctors, of course, we have play a very big role. But apart from the doctors, family, friends, and community, individuals, and of course, health service care or healthcare providers are the most important thing. Persons in their, in their life where they can actually go and report. What is the role of the family? I think the role of the family, friends, and the community cannot be denied. It is a huge role to play. A recovery from the violence dependent on the extent of support received from the loved ones. So many times in the movies and other things, we see that whenever there is anything wrong, if there is a support from the mother, father, and so many things there in Dr. Jaideep Malhotra's year, I remember a rape victim was there who was raped by the superintendent of the police, and she stood against because of her father, who fought the case, saw to it that the punishment occurs to the person. And I was so much moved by the support the family gets. So support of the family is extremely important. Recovery from the violence depend on the extent of this thing. Health professional and engage with the family, discuss ways to provide the survivors well-being. They have to see that now further what action is to be taken, how they are going to be, surviving, and how they should be carrying out their normal life or whatever activities they are doing. It should be discussed with all the caretakers that it should not be held responsible for the this thing. That the person who is the victim should not be held responsible for the assault. Child sexual abuse, parents may experience anger, confusion, guilt, and blame. Then reiterate that it is the perpetrator who who misuse the position. So it is not the victim, because so many times they blame the victim only. And I think there were a lot of hue and cry when the senior politicians told that women should wear this kind of clothes, they should cover themselves. Otherwise, it was such an incorrect statement to advise to the victims only. Now, what is the role of healthcare providers? Role of healthcare providers is very big, and we have a full book on the PET, that is a prevention, examination, and treatment of domestic violence in the sexual victim. There is a book is available written by me and Reena. So there we have given this all total role of healthcare providers, how actually we examine the patient, what exactly we do, how we report, and how we take the conclusion. So all the women are likely to seek the health services at some point in their life. Healthcare providers are often trusted. They trust us instead of police or court. They trust us. They trust the physician and the examiners, serve as a role model in the community. Doctors are treated very high, respectfully, and violence is an underlying cause of the injury and the health. Now, again, the same that role of healthcare provider, creating an enabling atmosphere, positive atmosphere, atmosphere of trust and mutual trust, and so that she can come out and speak very clearly what happened to her. So we have to speak to the survivor in a very private space, recognize her courage and reaching to you. I just told everyone 70% people they do not reach, they don't want to report on. So at least she is so much courageous that you are reaching to you and giving her history, and she's overcome all the several barriers. So very important. Recognize the dilemma faced by the survivor in reporting violence. Do not label non-reporting to the police as a false case. You should not be judgmental in saying any of the false case. You have taken history, you have done this. Let them collect the evidence, let them that it is their duty to do, and then they decide whether it's a false case but you don't label the patient as a false case. Assure the survivor that the treatment will not be compromised. Inform the survivor of available resources, legal rights, so that they can. And I want to just inform you also, there is a service provider in the Domestic Violence Act. There is a service provider post, protection officer post, and then they also can be approached officially apart from the police and the doctors. What is the role of healthcare? Then facilitation and demystification of medical procedure. The health professional should prepare survivor for an internal examination, because if she is adolescent, and she is so frightened, so it will become very difficult. So you have to counsel her. You have to tell her that what exactly you are going to do, what examination will, procedure will be. Explain to the various stages of exam. We always do a speculum, if it is a speculum, pervaginum, whatever, smear collection, all these things, please explain to her. Communicate the rationale for referral for X-rays and the UCG, USG, and the age estimation, amongst others. Of course, you have to know if possible, try to take the Aadhaar card also, but estimation of the age is so important. So I remember in good old days, we used to send them for ossification, then X-ray, and other age estimation indicators. So you have to communicate with the rationale of referring them. Then role of healthcare providers, addressing the survivor's emotional needs. Recognize the survivor may present in a varied image. She may be depressed, she may be violent, she may be, sleeping, and she may withdrawn from the social this thing. So all this she can present as. So encourage the survivor to express her feelings. Encourage her to survivor to seek the crisis and counseling. Assess for the suicidal tendency or whatever. Make a safety assessment and the safety plan, and involve the family and friends in healing the process. So this is a little long term, but we have to actually judge what kind of mental condition she is going through, and accordingly you have to make a plan. Now, how to communicate? How to communicate, very, very important. I remember a case who was a table death in our hospital once, and the residents were there, and suddenly one of the residents goes and just informs, oh, patient is dead. After that, aftermath was so much you can. So any kind of direct information, telling bluntly, all these things, I think by this time we have become very experienced. And now what exactly you have to say, that you have to say the patient, if she's just holding herself, then take your time. Whatever you want to share, please share. If you don't want to share much, then don't share. But otherwise, take your time and decide. Or you can say, I can imagine that you have been going through a very hard time, or you had already had such a bad experience, etc. You take a tremendous amount of strength and share what has happened. So you are both, you are a very bahadur ladki hai, whatever Hindi mein or language that you have come here, so I think we should encourage her to speak. How do you think that we can help? And you have to tell her that how should I help you, what exactly you want, and you tell her that you are not alone, we are with you, and whatever best possible we are going to do. Now the practical approaches is how the examinations and things should be there. She should be sitting position, open posture, leaning forward. There should be eye contact, and she should be relaxed. This is the ideal position for the practical approaches. Now supporting the GBV survivor along the LIV. So LIV is a listen. You have to listen. When we motivate her to speak, then you have to listen whatever story or whatever things she's trying to say. Then in between you inquire few of the questions. Then after that you validate what exactly then you are going to validating it. You have to enhance the safety, and then you do the support. So this is a lives. Then listen. How exactly listening is so important to the patient. Use verbal or non-verbal means to show support and communication. Your body language also should be such that you are comforting the patient, you are listening carefully, you are not distracted by your telephone calls or something, cursory way. You should not ask the questions. It should be open-ended question, focused question, ki kab hua, kya hua, whatever in her own language, and etc. And use very good body language. Your body language should be very good. Posture, and you should have eye contact, so that she feels comfortable, she feels trustworthy, and then you make her talk. Then avoid the leading question. Should not ask penetrating or ऐसे leading question and compound question. इसके बाद ये हुआ था फिर वो don't make so many questions together. So listen carefully. Eyes giving your undivided attention. You are just looking at her. Ears, of course, you are listening to her very carefully. And heart with caring and reassuring way. So I think this is the ideal way we should do it. Do's and don'ts given very, very well, that how you act, be patient and calm. Let her know that you are listening. Your attitude should be, acknowledge her, whatever she is feeling. In between, you comfort her. What you say, give her the opportunity to say that she wants to say, how can I help you? Encourage her to keep talking if she wishes. Let her talk. Sometimes, some people just want to, take out all whatever is inside. So let them talk and, give her proper time so that she understands, that she has explained everything to you in detail if she wants to. And do's and don'ts, don't pressurize her to nahi batao, or that kind of thing. Let her be her natural self, and I think that will only give her comfort. Don't look at your watch all the time, that are jaldi karo, etc. Don't judge what she has or not done, and don't say that you shouldn't feel that way. Don't be judgmental. That is only one thing I can say. Don't assure that you know what is best for her. Don't decide what is best for her, and don't interrupt in between till she finishes. So these are the few very, very important points given to the examining doctor. Then allow for a silence. Once she finishes her story or her whatever experience, let her, allow for some silence. Stay focused, acknowledge. Don't try to finish her thoughts. Don't tell her that she's someone else's talk about her own trouble, and don't think and act that you must say that this problems for her. So these are very important things. Inquire about the needs and concerns. So once you heard about her problems very patiently, given her a positive, confidence, trust, then you have to act. So this is a phrase, you ask the question, invitation to speak. It should be open-ended question. Like you said, कब कैसे हुआ था? This is what she's narrating in between. You ask open-ended question instead of yes or no. Complete the sentence. Ask properly. Check your understanding by restating. Says that reflect back to the client the feeling that they express or explore as needed. Ask for clarification if you don't understand. Sometimes she mugs up, or her sentence not proper. So you please, for understanding, ask her for clarification. नहीं मुझे ये समझ में नहीं है, तो please मुझे फिर से बताइए. And help her to identify and express her needs. She wants immediately, suppose she's having a pain or she's having whatever she wants, so immediately identify exactly immediately what she wants. Her needs, apart from your medical treatment, of course, concern some of what she has expressed. Inquire. So inquiry, these are a few points which are given in how you are going to inquire. What would you like to talk about? So of course she has come with all this, sexual assault or any other domestic violence and all those things. How do you feel about that? You mentioned that you feel very frustrated. It sounds if you are feeling angry about that. Could you tell me more about that? Suppose she has just short sentence, aisa hua tha, somebody came, etc. Then ask little question, and then you tell something more about it, because I do not understand, because you are going to validate that, writing so important for you to understand. Can you explain that again, please? Is there anything that you need or are concerned about? And you seem to be saying that. So these are the few of the suggestions that how to inquire. Now listening, inquiring, now validating. So validate, we have to understand that validate does not mean to try and verify the survivor story. Whatever she has said, everything is totally correct, and then you are writing that this thing. So for example, through interviewing the alleged perpetrator or witnesses, this is not safe, appropriate, ethical recommendation. So for example,
Madam, sorry to interrupt, but can you just wind up the talk?
Okay, it has done. Empathy versus sympathy. You have to be, sympathetic, and we should have empathy. Sorry, I did not know how much time, because they have given the lecture to me, whatever lecture. Ignoring the violence can do more harm. Yeah, okay. I will not going to read. I think the module will be shared with you, but this is the last slide. Okay. So the doctor helped me to feel better by saying that I don't deserve the treatment and help, and you may be his excuse, but you are never the reason for his violence. So mental health supports linkages are there, health, psychological support, legal, security, and want the referral practice help to reach the further. So I think they have given a wonderful module, and it is very detailed, and everything is we should know as a and how to examine and how to proceed. So I think thank you very much, and registration and pre-test is necessary. Certificates will be awarded to the participants pre and post and feedback. So thank you very much for patient listening, and Pratik for sharing the presentation. Thank you very much.
Thank you very much, Mandakini ma'am, for such a beautiful and lucid presentation, speaking to us about the humane approach women who have been facing violence and violence. I take great pride and privilege to welcome our next speaker, Dr. Ramani Devi. She is a past Vice President of Proxy. She's been chair of the Endometriosis Committee. And during her tenure at that time, she had introduced the GCPR on endometriosis. She's here to speak to us regarding the effects of violence against women in pregnancy and newborn. And I must mention here, since it's particularly pertinent, that she's one of the chief contributors to this entire slide deck and this program of violence against women, the Dheera program, which is the flagship program of our CPS. Over to you.
Thank you, Dr. Pratik Tambe, for making me a part of this wonderful Dheera program, and thanks to Mox as well as the President Dr. Shantakumari and my dear friend Dr. Madhuri Patel, Secretary General. The topic today that is given to me is what is the effect of violence against women on pregnancy and the newborn. So it's very, very important, because pregnant women, when they experience intimate partner violence, the loss is not going to be only upon the mother, but also the newborn is going to get affected. So first, few questions before I start my presentation. Have you ever seen patients in your OPD who have been victims of violence or abuse, and how do they present? And how have you diagnosed? And what are the common clinical presentations? And can you recollect a case scene? See, I would like to share one of my experience in regarding this intimate partner violence, which happened in my antenatal, one of my antenatal patients. She was a lovely girl, 24 years, primigravida. She used to be bubbly. So every time when she comes to the OPD, she used to have a good chat with everybody in and around. So one fine day when she was 24 weeks plus, she came and she was sitting in the OPD very quietly, and she seems to be depressed. So my people who are outside, that is front office people, they came and told me, Madam, this girl used to be always talkative, but I don't know, today she's very much silent. There is something wrong with her. So that her presence of keeping away from her routine activity had pointed even the front office staff to think about something has happened. So when she came inside the room, I asked her, what happened to you, Ma? So then initially she was a bit reluctant, and then I didn't force her. Then again, after 2 or 3 days, she came back telling some vague complaints. So this second or the third time I caught her, I made her sit and talk with me personally. Then she told me that there was some problem between the couple, and the husband had better. So she was having some irritable uterus, and she was having depression and all those things. So this was some methods how these girls might present during pregnancy. So this is questioning them indirectly to some extent will help us. So you even the way she behaves, way she approaches us, and these are all some of the methods where we can identify that this woman has suffered some sort of problem. So the common clinical presentations are like, the first thing is, apart from the violence, apart from the injury that she would have sustained because of the violence, she would have been mentally affected, and the fetus should have not taken proper food or anything, so that as a result of that, there will be some sort of IUG or some obstetric complication she can have. So there are high levels of violence during pregnancy. This was when a woman in Peru, when she was interviewed, she said that he hit me in the belly and made me miscarry 2 babies. I went to the hospital with a heavy bleeding, and they cleaned me up. So this was something, not an uncommon thing to be presented. Don't think that it can happen only in Peru, because all the statistics data will show you that intimate partner violence can happen in any country, both developed or underdeveloped countries or developing countries. Around 41% of the women, that is 61 million in the world, are affected by intimate partner violence. So it starts not only during once when the woman gets married, but even a teenager or in the reproductive age group, or even in the perimenopause, any woman can get affected with sexual violence or physical violence. So roughly it could be even 1 in 3 or 1 in 5 women, they do suffer from this. And if you look into the suicidal, that is the tendencies are also increased because of this sort of domestic violence that is existing. And again, if you look into the homicide, the woman would have undergone, if you find out that 1 out of 5 homicide victims are very often killed by the intimate partner. So they also suffer post-traumatic stress disorders and so many other things. Not only the lady is affected, but the whole family is distorted. And if she has her elder children at home, they are also affected. So to go through the case study 1, she was a primigravida presenting with the premature rupture of membranes, prolonged obstructed labor. She presented with the rupture uterus and shock, and ultimately she lost the battle. So the history that was taken in detail later revealed that it was a brutal kicking on the abdomen by the husband and pushed violently, falling on a sharp edge. So the death here was due to violence. So going to the case number 2, it was a gravida 3, para 2, live 2. At 28 weeks of gestation, she had previous to LSCS, She landed up the hospital with an antepartum hemorrhage in shock, and she was a known case of placenta accreta. And ultimately, she landed with hysterectomy, where she had massive blood transfusion, and there was bladder involvement also. What precipitated the bleeding? Ultimately, it was the husband who was kicking on the abdomen. So coming to case study 3, see, sometimes it can present domestic violence can present as some sort of obstetric emergency. For example, a woman with severe preeclampsia and unconscious, or eclampsia with a CVA leading to maternal mortality. So the thing was, it was thought that the death was probably due to eclampsia, but actually what has happened is, it was the violence by the husband, and the postmortem showed that there was a fracture of the skull and the cerebral hemorrhage, direct death that was due to violence. So hidden violence that can masquerade as a maternal disorder. Then coming to case number 4, she was a Gravida 3, Para 2, Live 2 with the previous 2 LSES which were full term, and she had a rod implanted because of the fracture she has sustained earlier. She collapsed in front of the hotel, brought to the hospital in 108, in active labor with severe hypertension, emergency LSES done with the consent of the RMO. So that could save the patient and the baby at the right time. So here what we have to think is, see, what has happened to her is there was no person who was accompanying that lady. So probably that shows that there is some mishap in the family, and that is why the patient has come alone or brought to the hospital alone. And the collapse what she has sustained is probably because of the domestic violence she has undergone, and she was probably thrown out of the house. So that she was pushed from the history revealed that she was pushed from the 2nd floor 3 years back and now abandoned in labor. So coming to case number study 5, that is, she was a Gravida 3, Para 2, no living, and then there is 2 neon deaths with the previous 2 LSES, and she was 36 weeks of pregnancy with a severe anemia. With this, she was brought to the hospital. Both times, they found out that there was history of physical violence, the kicking on the abdomen by the husband brutally, that is followed by the loss of fetal movements and intrauterine death of the fetus. So she has had previous 2 LSES, IUD, both times history of physical violence by the husband. And that the 3rd pregnancy, probably it had alerted the parents who took her home, and severe anemia was corrected by transfusing blood, and LSES was done. So what could be the reason for the severe anemia? Because probably because of the domestic violence, she was not taken care by the husband and the other family members, that had led to, and probably she has not had a routine antenatal checkups and not taken a routine iron supplementation or etc. That has led to severe anemia. So then coming to case number 6, she was a G6, Para 2, Living 2, and 3 abortions, previous 2 sections, 3 induced abortions, all presenting with, this time she was presenting with acute hemorrhage, shock, sepsis, and incomplete abortion. So there was severe form of physical, emotional violence that forced abortions. And then the detailed history brought out by screening received, this history was brought out that she was forced to undergo induced abortions, and she received 4 transfusions. See, this can happen. Why all 3 induced abortion? And in the current scenario, maybe the couple, they did not have a male child, and the previous 2 were female children. So in order to have a male hair, probably this woman was forced to undergo induced abortion once when they knew about the sex of the child. So this forced sort of abortions as well as physical and emotional violence has led to this sort of complication. So this is a picture of a woman where you can see she was brutally injured by some weapon, and it was showing some multiple injuries over the lateral side of the face. At the same time, when she underwent a laparotomy, you can see an injury in the uterus. So this was a stab injury by the husband who was inebriated, lacerations in the face, as well as perforation of the uterus leading to intrauterine fetal death. So ultimately, the patient underwent laparotomy and rent repair. So what we identify from all these case scenarios are that as obstetricians, a specialist, we have a stakeholder in women's health. We hold a unique position, that is to assess and provide support for the women who experience violence because of the nature of the patient and the physician relationship. So any problem that happens for the antenatal mother at home, intimate part, be it an intimate partner violence or be it a violence from the household members, the first person she will be meeting in person will be her own gynecologist, who should be kind enough to listen to her. So there are many opportunities for intervention that can occur during the course of adolescence, that is teen dating violence. So the adolescent can be brought to you with some form of depression or some injury, who would have undergone domestic violence, or during pregnancy should have been brought, or during family planning meetings, that is when the patient comes for some advice regarding family planning, we can have a talk with the particular patient regarding this domestic violence. Or the woman will, when she comes for regular annual checkups or other women's health visits, maybe we can get some clue regarding the problems that women is undergoing at home. So then how to elicit history? We can indirectly put questions that may be like what madam has said. So we can ask her, are everybody all right at home? Are you comfortable at home? Are you having regular meals? Are you being taken care by the family members? So are you getting along with your partner very well? So these are some of the leading questions what we can put to the patient, and we can get the answers. So there are a lot of screening tools also, that is abuse assessment screen, humiliation, afraid, rape and kick, that is HAR screen, hurt, insult, threaten and scream, hit screen, ongoing abuse screen, ongoing violent assessment tool, then partner violence assessment screen, then slapped, thrown and threatened screen, and woman abuse screen tool, women's experience in battering scale. So in WHO in 2018 recommends that all health professionals should be trained as a first line response to family violence. I think with the introduction of these Dheera program, all the obstetricians or gynecologists are very well versed as far as Indian FOXI members are concerned, and we have developed a sort of interest towards listening to the patient and responding them for the family violence. The steps are to be to listen, believe in the patient what they say, inquire about the needs, validate the personal experience, enhance safety and offer ongoing support. Universal screening or routine inquiry, is it necessary? It's not needed in any, routinely we do not inquire them regarding the domestic violence, but however, WHO guidelines identifies antenatal care as a setting. A routine inquiry could be implemented if providers are well trained on the first line response and minimum requirements are met. So like our routine patients, as we see them, we can find out whether they are happy or not, or unhappy, and whether they have been exposed to some sort of this domestic violence. We can pick up right from the face, from the behavior, from the talk, and so on. So we are the first people to meet with them. So then ensure safety. The evidence on benefits and potential harms of clinical inquiry and subsequent intervention is lacking or uncertain. A minimum condition for healthcare providers to ask women about violence is that it must be safe to do so. That is, partner is not present, and that identification of intimate partner violence is followed by an appropriate response. So probably if the couple, they come, the patient, the lady may be a bit hesitant to talk in front of her husband. So at least by telling the husband to stay outside so that you want a have a detailed examination, we can inquire the particular patient in person whether she has got any problem at home. So detailed guidance on responding to intimate partner violence and sexual violence against women can be found in 2013 WHO clinical and policy guidelines. So this is what, not only that, apart from the maternal problems the woman might face, a lot of case scenarios they have shown that it can cause any abortion or premature labor or intrauterine fetal death, and some situations, if the baby is born, the baby may have IUGR and sort of other problems which can lead to early neonatal death also. And thanks for the opportunity, Dr. Pratik and Moggs. Thank you.
Thank you very much, ma'am, for being here and for sharing all those personal experiences. Who's talking intimidated there?
Yeah, thank you, Pratik sir. Thank you, Madam, Dr. Ramani Devi, for such an elaborate talk. It was wonderful listening to you and understanding the entire concept. I would now like to welcome the next speaker, Dr. Parikshit Tang. He's going to speak on mental health. Dr. Parikshit is a MOJS Managing Council member and a Youth Council mentor. I would say that he's a friend, philosopher, and guide to all the Youth Council members and a person to go to for a genuine non-biased advice whenever anybody wants to. And he's also associated with Ashwini Maternity and Surgical Hospital and Jupiter Hospital in Mumbai and treasurer of Foxy.
Thank you.
Yeah,
Thank you
that's
so
it,
much.
sir. I'm going to stop it there.
Very kind of you to say such nice things about me. And Pratik and I know that we are stressed for time. And I'll be very brief about this important topic about mental health issues in women who have suffered violence. And my thanks, of course, to Dr. Ramani Devi, Deepa, and Kiranmay and Ajay for this presentation, which I'm going to use to highlight some very important aspects of this situation. Now, let's take this typical case report, and we've seen these kind of scenarios which have been described. 26-year-old woman brought to the hospital, sudden abdominal pain. She was 28 weeks pregnant and married for a year, and this was the first pregnancy. She's a booked patient. Everything looked okay. Vaginal examination, abdominal examination, except for a little irritable uterus. But, the whole thing looked, as Dr. Ramani Devi was saying, a previously cheerful, bubbly girl, a change in the attitude. And that's what must have led to this inquiry. And that's where the inquiry got us a result that, yes, she was being beaten by the husband. So the immediate questions which come forth are, what details should we ask? Should we tell the police how to counsel? What are the problems that she's coming across? Should we involve the family in the counseling? Should we prescribe her some drugs? And what's the long-term impact of this intimate partner violence that she has faced? So this is really a situation where we need a group approach, and it should involve the obstetrician who has been responsible for picking up the problem, a psychologist, a psychiatrist, and that's how you come to a reasonable kind of a situation where you can really give justice to this clinical scenario. Now, one might wonder, that, okay, it's nothing great, it's just a small injury, then why all this mental health support? But believe me, mental health issues are much more prevalent than gross physical injuries, which happen with intimate partner violence. There's a lot of suffering which is there behind every bruise, as they say. So because of all these things which can happen, which you are reading on the slide, there's a hypervigilance, anxiety, mood disorders, including suicide, substance use problems, sexual disorders, phobias, later on, post-traumatic stress disorder, social withdrawal. All these things are some things which can happen because of violence against women, and they will be all right only if this woman is adequately supported mentally. Now, the role of the obstetrician is really threefold. One is risk assessment. Means how often is this happening? How bad is it? And since how long has it been going on? Is it something which poses an immediate and clear risk of physical danger to this particular woman? The second is safety, which carries on from the same theme, that from further assault by the same partner? What is the risk that this woman might be contemplating suicide? And you do an assessment to judge, what is the homicide risk in this particular situation. That will give you an idea about the degree of alarm that needs to be raised in this situation. And these are the danger signs that you need to look out for. Frequent visits with the same type of problems, severe injuries, alcohol in the mix. There's a threat that the woman says that my husband has threatened that he's going to kill me or rape me or assault me. The woman is feeling so depressed that she's thinking of ending her own life. There is access to a weapon, or if the partner comes across as extremely jealous, then these are all situations which will alert the obstetrician and prompt isolation. I shouldn't say hospitalization only, but isolation. That means you don't want the partner who has perpetrated this violence to be in close contact with her. So if there are these kind of features, then yes, certainly we would think about hospitalization. Now, the multidisciplinary treatment plan is all that is essential. And this will be in certain headings. Milieu therapy means changing the environment in which this woman is. Mood stabilization, either by counseling or by medications. Evaluate what kind of medications she needs. And then a little long-term planning in terms of what psychosocial support this woman has. What's the infrastructure she has? Does she have any financial wherewithal to separate from her husband if so needed? And of course, all the legal cognizance which has to be taken. There's a concept of a trauma recovery clinic, and the objective here is to enable survivors of trauma to reclaim their lives, to rebuild, enhance their self-esteem and resilience. And this, believe me, does not require some great ICU infrastructure. What it needs is human resources, and this kind of centers can be set up as and where it is needed. The psychosocial impact of violence is very profound, and all these things can happen to women, including shame, isolation, helplessness, and progressively the woman starts losing confidence. The bonding that she'll have to her own child is going to be disrupted. And that's why we need a psychologist, a psychiatrist, and these are all the various therapies. I'm really not going to just sit and read out their names because I understand almost as much as you. Here's where you bring in the specialists so that they can do either as a cognitive behavioral therapy or a brief trauma focused CBT, whatever needs to be done to bring this woman out of her situation. These are various type of skill building processes, skills training in affective and interval regulation, which can be done. Again, it's something which the psychiatrist and the psychologist is going to decide, including interpersonal psychotherapy. And ultimately, what we are going to do is relieve the impact, the mental impact, what this woman has faced because of the violence that she has undergone. Plenty of drugs which can be used very safely in pregnancy. And here, I think it's an important taboo or a myth that obstetricians need to get rid of. Most of the antidepressants and the mood stabilizers, they are very safe in pregnancy. And especially after 7-8 weeks are over, there's really nothing much to worry about in using these drugs for pregnant women. So invariably, what's going to happen is the psychiatrist is going to say, okay, I'm going to give you this drug, but you need to get a clearance from the obstetrician. So that's where you have to step up and say, yes, you're right, take this drug, and that's going to do a world of good for you. Of course, I mean, usually the perpetrators of violence are men, and there has to be some focus on men owning up to what they've done, taking personal responsibility, challenging these attitudes and beliefs in a group therapy, and developing skills for interacting and reacting non-violently with others. So this is something that is like a food for thought, really. But our immediate concern is the mental health of this woman who is in a state of crisis. So mental health is an issue in violence-affected women, and therefore this needs to be assessed and addressed along with the physical health. So thank you very much, and I'm very glad that all of you are here for this program. It's a really important one, and please do take part in the pre and post tests and give your feedbacks. Thank you.
Thank you, Dr. Parikshit, for keeping to time and drawing attention to what is commonly an iceberg phenomenon, where most of us don't realize that mental health issues are so prevalent. Thank you very much for sharing your precious time and working with us, sir. I'd like to introduce the next set of chairpersons, Dr. Amir Purandare, Vice President of Vermont, member of the Managing Committee of the Society, and Dr. Komal Chavan, Chairperson for the Proxy Medical Disorders in Pregnancy Committee, and also somebody who is vital asset to our president. Over to the next set of chairpersons. We are hard pressed for time, so we will do the pleasantries here. Can I request the chairpersons to introduce the next speaker, please?
Yeah, Pratik, could we have the CV slide, if possible, of the next speaker?
Unfortunately, we are not allowed to share
it may not
slides.
be always possible to do that. So you can very briefly introduce whoever's coming up next in a couple of lines, please, if you don't mind.
Okay, sure.
Thank you.
So, yeah, so it gives me great pleasure to introduce Dr. Sujata Darvi. Is Madam there?
I think she's on her way, but Dr. Kiranmai has been there since the beginning of the program, so maybe we can have her instead.
So can we go ahead with Dr. Kiranmai's talk?
Yeah, please.
Yeah, gives me great pleasure to introduce a close friend, Dr. Kiranmai from Hyderabad. Dr. Kiranmai is a very active Foxian and one of the key members of the Dheera project of our beloved Foxy president, Dr. Shanta Kumari. Dr. Kiranmai is very well known for her academic as well as her clinical pursuits, not just in all of Andhra Pradesh and Telangana, but nationwide. And she has worked tirelessly in this project. And I request Dr. Kiranmai to please proceed with her talk. Thank you.
Thank you so much, Dr. Ameya. And thank you, Dr. Pratik and Dr. Parikshit and the entire team of MOX for taking up this program and inviting me to talk about this important topic, that is support systems and resources. Hope I'm able to, sorry. So actually the topic before is the challenging situations in violence against women. Are you able to see my slides?
No, ma'am, we are not able to see. There's just
Blank screen, madam.
Just shared.
Maybe you can stop sharing and restart again.
Yeah, it seems stuck.
Just close the presentation and open it again. Sometimes that way.
Not able to do it actually.
Do you want me to share from my end? Support? Can you allow me to share?
Just a minute. I'm not able to stop it also. Can you share it otherwise?
Yeah, I'll share from my end.
Yeah, sure.
Just have to say next.
Yeah. Is it visible now?
No, ma'am, we still can't see yours. But I think mine is seen.
Yeah, we can see.
All right.
No, I think, yeah. Yes, thank you, Dr. Pratik. So my internet seems to be a little bit, I'll just switch off my video. Yeah. So am I audible?
Yes, Dr.
Yeah, thank you. So coming to the support systems, I'll take Dr. Pratik, next slide, please. So the overview of this section is that, okay, we have We know how violence against women plays and against women's health, what is the intersection, what is our role, and how to examine what are our attitudes, and then what about the mental health, etc. Now, next, how are we going to help this woman ahead? And what are the protective laws that are there, and what are the helplines? And we hear a lot about these one-stop crisis centers. What do we need to know about them, and how can we link up and help in the rehabilitation of the survivors? Next slide. So the Protection of Women from Domestic Violence Act 2005. Actually, this presentation is made by Dr. Ramani Madam and team. So thanks, Ramani Madam. So next slide. So we had 498A in the Indian Penal Code, which was way back in 1983. But then why did we need this? Why do we need this Domestic Violence Act 2005? The reasons were that in 498A, there was no emergency relief available to the victim. And the primary purpose is to first immediately, provide relief to the victim and take her issues. And then that is the primary issue for us. And the remedies available were linked to matrimonial proceedings. So if a woman was married, then only this 498 was applicable, and court proceedings were always protracted, during which period the victim were invariably at the mercy of the abuser along with him in her home or her parental home, and relationships outside marriage were not recognized in this 498A. Next slide. So again, why domestic previous? So 2005 is a civil law. In 498, a husband is liable for punishment, but wife does not get any financial relief. But in DV, as we have told previously, that the female partner gets relief, but there is no punishment or arrest unless the husband violates code. So the primary aim is to provide relief to the woman. And another difference is 498A can be booked against only husband or his relatives, but DV can be booked against male members of a family. Next slide. So who can be a complainant? It can be a wife, a woman based on consanguinity, marriage, adoption, cohabitation against a male abuser in a shared household, and a woman who is in relationship to similar to marriage with a man. Technically, a transgender male to female can bring an action against a transgender female to male, and a woman in live-in relationship with an unmarried man, but not with a man who is married, if she knew or ought to have known that he was married. And anyone can file a petition with the survivor's consent. Next slide. So whom can she complain? A protection officer under this act, the service providing center like OSCC, and then the medical officer in charge there, or a police station or a magistrate. Next slide. Then the jurisdiction under this act is where can she complain? Where wife permanently or temporarily resides or carries on business or employed, or where husband permanently or temporarily resides or carries on business or employed, or where this action of violence has arisen, or the wife can choose any of these three options, wife or the partner or the female person. Next. So the type of orders is, as we are stressing upon, immediately it is the protection order, and immediately to stop violence, emergency relief, and the residence in the shared household, which is completely protected, irrespective of whether she has any right of ownership or lease. And she can also require a separate housing, and the abuser has to provide, and a custody order, compensation order, and violation of any order any order is an offense, and magistrate may charge offense. Next. And non-compliance of protection order by magistrate can lead to issuance of non-bailable warrant. This is an important section 31 in the Act. Next. So the time limit is, unlike the 498A, it requires that all proceedings brought under the Act be disposed of within 60 days of the first hearing, and this hearing should happen within 3 years following the application. So you can realize that it is a really short time frame, and the services offered is she can file filing an investigation report, directing the complainant to a shelter, facilitating free legal services and counseling services too. Next. So apart from this 498A and the Domestic Violence Act, we have in our constitution, thanks to our constitution, the Article 14 on equality, which doesn't compromise, and thanks to which we still are ahead of even the so-called developed nations as far as women's rights are considered. and then the National Commission for Women, which was established in 1992, and the Dowry Prohibition Act. These are the other domestic legal remedies we should be aware of. Thank you. Next. So again, one-stop crisis centers is something which has come up to a large extent pan-India. This is one of the first one-stop crisis center in Madhya Pradesh, Gauravi, wherein it's all in one, at one place. The woman who is a victim or a survivor can just walk in with an assurance that their consent and confidentiality will be respected and protected, and all the medical, legal, and the psychological needs, everything is taken care of. The police is there, the medical officer is there, the nurse is there, the legal advisor is there, and then the psychologists are there, psychiatrist is there. So actually now at present there are 234 one-stop crisis centers all over India. They are more popularly known as Sakhi centers. If you Google Sakhi centers, the entire list comes out, and you can really help it out. I mean, it's within your reach, and you can help the patients or survivors to whom you need. You can extend the help. Next. Then this is our She Team Bharosa Trust. Even before the Sakhi centers had come up, Hyderabad, the government and the police have brought out this one-stop crisis centers. She Teams is a household name in Hyderabad and Telangana. Wonderful work. The helpline is 100, and we have visited it, and it is a wonderful, wonderful place. It's a real confidence booster to all the survivors. Everyone is there, and they're doing wonderful work, liaising with the government, doctors, police, and then everyone who is the stakeholder in this. And a woman can walk in again absolutely fear free, and be sure that her interests are safeguarded. Next. So I'd not read out the next 3 slides, but if interested, you can take screenshots of the next 3 slides. These are the resources, actually, phone numbers, whom to contact, because some of the doctors have really called and asked what to do really if we have women patients who need. So these are the helplines, the All India 1091 181. Next. These are the different state helplines which we had procured and put it in one place. I'll not go through the entire list, but now Sakhi centers are all there on Google with all the numbers, email IDs. Even a small town and a place like where I've been working recently, Vanparthi, has a Sakhi center. I was pleasantly surprised to see a Sakhi center over there. And the police are so women friendly, and they do interact with us whenever we give opinions in medical legal cases and see that the interests of the women are protected. Next. Next. So that ends my presentation, and I thank once again Mox for this opportunity.
Thank you, Dr. Kiranmai. I think it was a very relevant talk because we should understand the legalities as medical professionals, what constitutes actually violence against women, so that we can be able to filter and guide our patients accordingly, depending upon this issue and trauma that they face. Thank you so much, Dr. Kiranmai. Also, it is nice to note that the movement of Dheera is really moving at the grassroots level. It has reached the grassroots level, and you yourself is witness to this, that it is moving way into the grassroots level, where actually sometimes the access to help is a great issue. So thank you so much.
Thank you so much.
I think Komal, if
Yes.
you want to introduce the next.
Yeah. So thank you so much. And at the outset, I would like to thank the organizers, specifically Pratik and Dr. Parikshit, for this opportunity and a very focused program on Dheera, violence against women. And I take pleasure to call upon the next speaker, Dr. Sujata Darvi. Dr. Sujata Darvi is the Clerical Secretary of Mumbai Obstetrics and Gynec Society. She's the Honorary Secretary of AMOX and practicing obstetrician in the south of Mumbai. So over to you, Dr. Sujata Darvi, for the presentation.
Thank you, Dr. Komal, for a kind and short introduction. At an outset, I would like to thank the organizers, first and foremost, MOGS President Dr. Niranjan Chavan, and FOXI President Dr. Shanta Kumari, FOXI Secretary General Dr. Madhuri Patel, for giving us an opportunity to speak on this CME of FOXI UNICEF Dheera, violence against women.
and for giving me an opportunity to speak on the topic of challenging issues and self-care in dealing with violence against women. I would also like to express gratitude to the coordinators, Dr. Parikshit Tang and Dr. Pratik Tambe, for formulating this program and for giving me an opportunity to speak. Can I share the screen? Yeah. Yes, so far as challenging issues and situations and self-care, so far as the workers which are concerned, who are concerned, and for the Dheera, that is those who want to help out the people who have undergone such sort of a problem, but they should also know how to deal with this challenging situation and how to deal with themselves and not get carried away by what the opposite party is talking. So challenging issues when dealing with a survivor who may be feeling hopelessness and having suicidal thoughts or in harm's way. That is, these are the people who are feeling quite let down, their self-esteem is quite low, and they do have this suicidal tendencies. Not that they will always commit something of that sort, but they're a little bit on a low self-esteem, and that's the reason they do have such sort of a feeling. So what would you do as a gynecologist, and the one when the patient comes to your clinic and she tells you that she is being threatened by maybe mother-in-law or maybe sometimes even some of the relatives in the house, and they're constantly pressurizing her to have either an issue or to have at least a male child or whatever it is, or she's unable to bear any children and they want her to have children, and she feels hopeless because they must have tried everything, but there is lots of pressure on her, and that is the reason you are the gynecologist are the first one that she would like to go and approach and talk to her. The doctor, can you do anything about the situation as such so that I can come out of it, or maybe you can explain it to my relatives or maybe my house people as such. So there are few ideas that can come up. Is you are able to recognize the signs of depression and a suicidal risk whenever a patient comes to you like that. You should not be afraid to ask whether do you have any of the thoughts of suicidal, because sometimes we feel that if we ask the patient, maybe she has not thought over it, and because I have asked. So if the answer is yes, that okay doctor, I do have sometimes, then it is always better to take it seriously and don't leave the suicidal survivor alone. If there is an immediate danger as such, you feel that okay, she is in the process that maybe she could commit something of that sort, then it is always better to consult some supervisor or some organization. Kiranmai already said there are so many organizations. You can always approach this organization and lead our patient or whoever is confided in you that these are the problems that she is facing, and that she feels that she could be having something of that sort. So it is always better to provide a referral to a gender-based violence agency as such. That is, this is just one-stop agency as such, where they can deal with all these problems and they will always be able to guide, so that maybe if at all patient or that person is trying to commit suicide, we can always bring her back to her idea of not doing something of that sort, or taking a drastic step as such. Obstetrics and gynecologists, should we ask the survivors about the thoughts and the attempts of suicide? Some of them, they feel that it could encourage a patient who is otherwise not trying to attempt suicide. Is it true or false? And then if at all you feel that way, then it is always better to ask the patient whether does she have any of these thoughts. And if at all you feel that okay, she is having any of these thoughts, it's better to refer the patient to some concerned authorities or maybe to some concerned this thing, so that she can be counseled and maybe she can reverse her thought of having a suicidal this thing. These are some of the questions that they have asked the people who are listening in the chat box. So basically, if at all you feel that way, then it is always better to ask the patient and refer them to a place where they can have a better plan as such. There are other few ideas that can come up to your mind. Is you should ask them about safety risk if at all she is planning to have something of that sort, and if at all she wants to have some of the, what are the safety plans in her mind, what are the strategies that she has provided if at all she wants to do it. And then you can always talk to her, and then you can always tell her that these are the things that you should not be trying to do it, and maybe refer her to a proper place as such. So one of the most helpful techniques for helping a survival is to get her out of that state by asking some questions which are not actually pertaining to her situation, but which are, surrounded by the situation as such, so that she can shift her emotional status to something, thinking in the own process as such. And then she needs a little short answer. That is, you can ask her about her family, how many children are there, whether she has any of the people who are very close to her, where she can confide into them. If at all she has children, then you need to ask her who's going to take care of the children. If at all you try and do something of that sort, how the things are going on. So that way you can just try and divert her attention, so that her attention goes off from the mind, and her mindset keeps on changing as such, that she does not have these suicidal thoughts. And even if these suicidal thoughts come to her mind, she always has to think that what if she commits suicide, and after her, how is she going to challenge, or what is going to happen to the family. So it's always better to have a proper conversation with the patient as such. There are certain challenging issues that times we encounter with the patient, especially when they're mentally unstable. I wouldn't call them mentally ill, but I would call them as a mentally unstable. So these are the patients, when you're dealing with them, you need to tell them who exactly you are, what exactly is your role. You have to be empathetic with them. You don't have to be sympathetic with them, but you have to be empathetic. Empathetic means you have to understand what exactly they're trying to do, and you need to find out some way out of it. It should be non-threatening, and you should be sincere in your intention as such. You should give them an honest and a factual answer whenever they try to put any questions to you. You should not be belittle about smaller things. You may feel, okay, what stupid thing they're asking to know, but for that particular patient, it is very important to ask you certain questions. You need to handle them properly. You need to give them advice which is also proper. Don't tell them that, okay, you need a psychological reference, or you need a reference to so and so, or you need a medication. If you tell them that, they don't take it in a positive way as such. You need to be little supportive in whatever problems they have it, and then maybe you can say you need a little bit of a more counseling. Either you can come back to me, or I can refer you to another counselor who would be able to counter, or who would be able to answer your questions well. So slowly and gradually, if you try and put confidence in that person will always come back to you and put she will be able to put in more of a thought process in your mind, and you will be able to guide her. And one should know how to activate emergency mental health checkup as such. So additional challenging issues, if at all you feel, can you be a mediation processor? What exactly is a mediating person? A mediating person is a person who is a mediating between a person who is undergoing this thoughtful process and person who is where you are supposed to refer these patients. So healthcare workers are basically a part of a survival centered referral mechanism as such, and mediation process itself maintains and contributes and abuses organizers over a survivor. So whenever you are mediating, you should be interviewing the survivor as such, and you should be interviewing the person who is trying to abuse that person separately and not bring them together. Try and find out what are the plus points from this side, what are the plus points from that side, and try and figure out something which is possible, so that this step can be negotiated as such, and this step the person does not take as such. And one also has to respect the rights of a survivor. So whatever confidentiality that a survivor has put into you, you should not be leaking out that confidentiality as such. The core safety precaution when dealing with these challenging issues or the cases, if you have a multiple people, then sometimes they are not able to handle it better, or sometimes one person is not able to handle it better. But even if you involve multiple people, there should be a proper multiple people. You should not have some random people coming from anywhere else. These are the people who know exactly how to handle these people, and these are the people who are quite experty in their own way. So that way you can take a help of multiple people. A service provider should never feel like that she should work alone with a survivor as such. A service provider should not work alone with both the perpetrators as well as the survivors as such. They should work with them either individually, or maybe they can appoint somebody else with you, or you can have your own colleague who can talk with the perpetrators, and the one person can talk with the survivor. If at all you're talking with them, you can always keep the door open as such. If at all one is feeling unsafe, you can establish a code word as such, so that whenever a survivor feels that she may have some harmful thing may be happening to her, that she can always use that code word, so that the co-worker will know exactly what to do and how exactly to help you out. One can also establish a relationship with a local police or a security. But whenever you're dealing with the police or the security, one has to be a little careful, because sometimes you put in these words to a local police or a security. Sometimes they tend to take an undue advantage of the whole situation, and sometimes it can backfire on you. So one has to be a little careful about the whole thing. And you can have also your colleagues as such who are at work, or if at all you're doing some home visits, you can always help them to do that. And you can use a supervision to address a security concern, or a group of people can address the security of an individual. Sometimes the individual threat is there, and you need a group of people who know exactly how to protect that person as such. So self-care for a provider, whether it is critical or no, and what exactly is a vicarious trauma, and then there are some comments on it, whether it is yes or no. A self-care provider is the one who should be aware of it, how to provide one self-care itself as such. Vicarious trauma is a change in the service provider's inner experience as an emotional engagement with the survivors of trauma and the stories as such. So the one who is providing care to the survivor as such, he or she himself gets involved into the whole thing, and that causes some sort of a trauma. And the changes that occur in a self-care provider could be physical or a behavioral state as a result of a constant exposure to the traumatic stories or the event. So you keep on listening to these stories and the event, and the person themselves get involved into the whole thing as such. And the causes of vicarious trauma could be constant exposure to the stories of trauma. You don't hear anything else, but only the stories you keep on hearing. You have a desire to help or change the cervical situation, but somehow you're not able to do it as such, because all the time the opposite party is little more on the stronger side, and you're not able to come out of the whole thing. There's also a feeling of powerless whenever a service provider does not see any change in the survivor situation, that you try your level best to change the situation, but somehow it is back to square one as such. Sometimes you overtly identify with the survivor as such, that is, you yourself gets carried away with the survivors and thinking that the service provider has power to change a survivor's situation, but sometimes one fails in getting it done. So how do you prevent or manage this vicarious trauma? That is, A, B, C are the mnemonics as such. So one has to be aware. Awareness is the first thing. That one has to get tuned to one's needs, limits, and emotions and the resources, and practice self-acceptance as such, that okay, these are the situations that each individual is having it. You should try and come out of it on your own, of course with the help of the people, but try and come out of it on your own, rather than having a big crowd and then not coming out to any situation, any solution of the whole thing. Balancing, maintaining a balance between your activities and also the rest. Rest is also very important, not only physical rest, but even mental peace is very important. And you need to have connection with the supportive relationship. You should have some friend circle or maybe relatives who are always supporting in whatever one wants to do it. There should be a communication, there should be connection. If at all you want to keep everything yourself, there has to be breakage of silence somewhere, so that you come out with what exactly one is suffering as such and what exactly is the situation. And that's why one can prevent the isolation if a patient has gone into a sort of an isolation as such. So self-care for the healthcare provider would be creating the boundaries in the workplace. Up to a certain limit, you can do it. Beyond that limit, you can't do it. Fine, just give it up. And maybe you can refer the patient somewhere else so that someone else can take over it. Establishing a support within your work environment, seeking assistance from an outside agencies, but outside agencies should be little more reliable, and the people who are working for that outside agencies should have a lots of experience as such, and they should be little more reliable as such, so that you can trust them as such, and creating your own self-care plans and following them through as such. So what exactly is the difference between empathy and sympathy as such? These are the statements. Sympathy means you try and sympathize. You have this pitiable situation and you always try to sympathize. Whereas empathy is something where you try and understand what exactly is the opposite person's problem, and then you try and give them some guidance. That exactly is what we call it as an empathy and the sympathy. And these are the comments. So the first one, according to me, I felt was a sympathy, and the second one, according to me, is an empathy. So these are some of the questions which they have put it. And that's all is my talk about how exactly to do about self-care so far as the help to the survivors is concerned. Thank you.
Thank you. Thank you so much, Dr. Sujata Darvi. It was a lovely talk. You covered in a very short time, very nicely, the challenges which we face, actually the trauma and the mindset of how to approach. So it was really, really very nice, but we are really short of time. There is a reminder constant from the conveners about short of time. So we will just go ahead with the next talk. Amay, you're there?
Yeah. So gives me great pleasure to introduce our next speaker, Dr. Madhuri Mendare. Dr. Madhuri Mendare is a very well-known faculty from the Sion Hospital and Lokmanya Tilak Medical College, Mumbai. She's also a member of the managing committee of MOGS and is very passionate about social causes in the Mumbai society and the various community health projects. So over to you, Madhuri. We are looking forward to hearing from you.
You have to cancel this dialog box first.
Madhuri, is your audio functional?
Just a second. Hello?
Yeah, we can hear you now.
Yeah. Without wasting any time, I thank our conveners and the organizers, brainchild of Dr. Shanta Kumari ma'am and Madhuri ma'am, for initiating this such an important topic. The slides are not prepared by me. They are standard slides given by Foxy, and we are really thankful for putting the entire information together. So the first thing, what exactly will be called as sexual violence? Now, sexual violence is any sexual act or an attempt towards this act or any kind of unwanted sexual comments or any acts related to traffic that would be directed against a person's sexuality using any kind of coercion by anyone. Now, regardless of who that person is in the relation to that victim, at any place, it can be home or it can be at work. Now, rape is a term that is commonly used for the first type of sexual violence that we mentioned, but WHO, apart from the definition of sexual violence, includes not only this definition of rape as a physically forced or otherwise coaxed penetration of vulva or anus using a penis, but also any other body parts or an object. Now, there are certain facts. There is a chance that there is a very high chance that you know somebody who's sexually assaulted. Victim usually knows the assaulter before the actual act has happened. The victim is never at fault. Her dressing or her being at a certain place at a certain time doesn't make her vulnerable for that act. Rape is the least reported and convicted violent crime in this world, and it is very much preventable and help is available. Now, the forms and contexts of sexual violence. A wide range of sexually violent acts can take place in different circumstances. To understand, a rape can happen within a marriage or a dating relationship. It can be by strangers. There can be a rape during an armed conflict. There can be unwanted sexual advances or sexual harassments that are including demanding sex in return as a favor. There can be sexual abuse of mentally or physically disabled people. And of course, children are the most soft targets. Forced marriage or cohabitation, including the marriage of a younger age group. Denial of the right to use contraceptives or to adopt other measures to protect one from sexually transmitted disease. Any kind of forced abortion. Any violent act against the sexual integrity of women, including any kind of female genital mutilation, even if it is on religious background. And obligatory inspections for virginity. Forced prostitution and trafficking of people for the purpose of sexual exploitation. Marriage is often used to legitimize a lot of forms of sexual violence against women. Marrying of young children, particularly girls, happening in many parts of the world. Legal in many countries is a form, even though legal in many countries, it is a form of sexual violence. Children involved are unable to give or withhold their consent. Majority of them know little or nothing about sex before they are actually married off. So the consequences can be, there can be pregnancy, there can be other gynecological complications, they can land up with sexually transmitted disease. A lot of mental health issues arise from here. They might feel that the only way to resort is going for a suicide or any kind of social ostracization. Now, the fatal outcomes of these would be suffering from AIDS or any related sexual transmitted diseases, any kind of homicide that they do as a reaction, or if they themselves have suicidal tendencies. The non-fatal ones is obviously unwanted pregnancy, further leading to some problems and infertility, sexual dysfunction, chronic pelvic pain, any sexually transmitted infections like HIV and AIDS, going into depression, leading into food disorders like obesity or anorexia, leading with recurrent urinary tract infections or GI infections, various complications related to pregnancy at that age group, migraines and other frequent headaches, a continuous feel of fatigue or nausea. The other non-fatal outcomes are like rape trauma syndrome, post-traumatic stress disorder, any kind of social phobia, shock, increased substance abuse, denial, fear, confusion, anxiety, guilt, depression, alienation, or eating disorders. How do you approach them? Sexual assault is one of the most invasive and intimate form of violence. A trauma-informed care approach should be utilized. This involves through understanding of neurological, biological, psychological, and the social effects of this trauma and violence on that particular individual. When a patient presents and reports a sexual assault, triage the patient as a medical emergency. Medical or psychiatric evaluation and stabilization is an immediate need of this patient. Activation of community advocacy to the bedside. A mandated reporting as directed by the state statutes. Offering and conducting, if desired by the survivor, the sexual assault forensic examination. Collaboration with the law enforcement. Prophylactic medications for STI and STD. Pregnancy risk evaluation, care, and safe discharge planning. Those providing medical and forensic care must always be prepared to provide testimony as either a fact or expert witnesses. So as a holistic first point person who the survivor has come in contact with, all these aspects need to be activated simultaneously. Now, application of trauma-informed care to the care of this patient that discloses sexual assault. There has to be safety, trustworthiness, choices being given, collaboration, and empowerment that is involved. Like when you approach this patient who's already in kind of a shock, when you enter, see that you knock, you ask a permission for the patient, meet the parents before you actually disrobe. Ask the patient to disrobe only when necessary or partially disrobe. Provide clear instructions. Identify the washrooms. Take time to familiarize with this person. Ask about the comfort level of the place as well as the environment. Share the control. Make her feel in control. Show respect. Use a warm and compassionate manner to build a rapport with the victim. Trustworthiness. Explain all the procedures in terms the person would understand. Tell the person what to expect and how long it will take. Ask the person what he or she wants. Ask if you can touch them every single time that is required. Ask before you invite any kind of additional help or a staff. Ask if you can close the door or open the door. Allow the person to decide where they want to be examined and where they want to be sitting. Explain the rationale why you are doing a particular procedure and how that is in favor of that particular victim. What the procedure will feel like and make appropriate modifications to handle that particular situation within the legal frame. Obtain consent for each part of your examination performed. Collaborating. Ask what are your top worries or concerns and address these first if possible. Share as much information about her worries or concerns. Encourage the person to make decisions about treatment. Empowerment. Ask what happened to you, not what is wrong with you. Never ask why questions as they imply fault. Why did you go there? Why did this happen? Why? Try to understand her mental situation. Take time with the person so he or she feels genuinely heard. Ask if the person has any kind of preferences related to or has any difficulty with a particular procedure. Ask the person what you should know before you begin the procedure. Ask if there is a way you can make the procedure easier for him or her. Ask if there is a way you can make the person relax or use a different position or wants her parent around her. Pay attention to her body cues. Many survivors have been conditioned to be passive and defer to authority, and so may not disclose any kind of distress during the procedure. The elements of the history. What's important is that you take a detailed medical history, the history of the recent past consensual sexual activity, any kind of medical history related to the assault, the sexual assault details as to location, where, how did it start, nature of the physical assault as to what degree the injury is, post-assault activities, whether she had bath, whether she changed her clothes, where all she went, and any kind of information about the suspect that she can share. Thank you.
Thank you, Dr. Madhuri Mendal, for highlighting something which we all have gone through during our medical college days, but most of us have forgotten. Unless we are in teaching colleges, we don't often have to examine such things. Amit, would you like to go ahead?
Yeah. Thank you, Madhuri, for that very practically enlightening talk. I think if we use these small, subtle messages that you have given, it will help a lot in managing these victims, especially in with respect to various sensitive issues that you have brought forward in your talk. Pratik, can we conclude the session, or?
The most important talk is actually still waiting, and Dr. Anita Sabarwal has been waiting for 2 hours for her talk, so it would be inappropriate to not allow this.
We can go ahead then with the talk.
Yeah, go ahead.
Yeah, so gives me great pleasure to invite Dr. Anita Sabarwal. Dr. Anita Sabarwal is a well-known gynecologist from Delhi. Most importantly, she is very well known for the academic sessions that she carries out in Delhi for the gynecologists. I think they are very popular, very sought after, and they bring about not just academic get-together, but also a fellowship of the gynecologists at from time to time, and and she's able to bring in unity also, and increase the passion of us working together. So over to you, Dr. Anita Sabarwal.
Thank you, Dr. Amya. I think that was too great an introduction. I don't think I deserve that. Thank you so much for your love. And I'm really privileged today, and I'm really feeling heartened and blessed that I'm here, in this prestigious this association of Mumbai today. So I bring greetings from Delhi, and thanks to Dr. Shanta Kumari for really including me in this Dheera program. And we are there for the last so many months, maybe we are together. So we've really enjoyed this whole journey. So thank you so much for giving me the opportunity to be the showstopper today with this last talk, which is very important. So am I allowed to do my share screen?
Please go ahead.
Yes. So yeah, you can see my screen. So I'll just shorten my. Yeah. So examination of survivor and collection of evidence, which is very, very important part of this Dheera program. And 1 minute, I think. Yeah, so why we have to talk about it, the role of a gynecologist. As we all know, when a murderer is there, he kills the body. Whereas when a person who's doing this, this criminal who's doing this sexual violence, he is actually killing the soul. So these people really need to be brought to justice, and no such criminal should go scot-free. And where now the role of gynecologist comes, because if they really, if they're able to collect the evidence in a very proper form and in a correct form, the criminal will never go scot-free. So the important evidence of crime, and that will help judges to understand the physical and mental condition of the survivor, and the reports which are collected, they can help to corroborate the survivor's story and enhance the credibility. And also the doctor can offer primary level counseling and treatment, and at the same time can refer for the physical and psychological sequelae. So medical examination, the following things, as my previous speaker just mentioned, we have to record the history, take informed consent, documentation of the injury, and evidence collection, which is very, very important to know the nature of sexual violence, the time elapsed between incident and examination, and whether survivor has taken bath or has washed, because all these help in telling us about the evidence and ultimately the opinion. So we include the general instructions, the medical legal examination report of sexual violence, name of the hospital, OPD number, inpatient number. Each and every word here is very important. And the name of the person, you have to mention everything, whether daughter of, wife or son of, whatever is known. And then address, and then also age as reported, date of birth if you know, and sex, whether male or female or others like transgenders. Then date and time of arrival in the hospital, date and time of commencement of examination is also very important. And then brought by whom, the name of that person and the signature of that person, an MLC number and the police station from where they've come, and whether the patient, the survivor is conscious, coherent, oriented in time, place and person or not, and any physical, intellectual or psychosocial disability. Interpreters or special educators will also be needed where the survivor has special needs, like has hearing or speech disability or language barriers, intellectual or psychosocial disability. So did I miss out anything? No. So then the informed consent of marks of identification, they're very important. I, so-and-so, daughter of, wife of, hereby give my consent for medical examination. This has to be documented. You have to mention whether yes or no for medical legal examination, and then for sample collection, for clinical and forensic examination. So all these parts have to be mentioned. And I also understand that as per the law, the hospital is required to inform police. And this has been explained to me, because if the hospital doesn't inform police, then they are also liable to the law punishment. And I want the information to be revealed to the police, yes or no, that has to be mentioned. And also I have understood the purpose and procedure of examination, including the risk as well as benefit, and which has been explained to me by the examining doctor. When my right to refuse the examination at any stage and the consequence of such refusal, including that my medical treatment will not be affected by my refusal, has also been explained and may be recorded. So contents of the above have been explained to me in this language, which has to be mentioned, and with the help of a special educator, interpreter or sport person, if we had any, that has to be mentioned. And also if we utilize the special educator or interpreter or the sport person, then that person's name and signature also has to be mentioned. So these things are very, very important. Each and every word here is very important. Then marks of identification, any scar or mole, and left thumb impression, that has to be done. Then comes the relevant medical and surgical history, onset of menarche in case of girls, yes or no, what was the age of onset of menarche, what is the menstrual history as we take it, cycle length and duration, and what was the last menstrual period date, that is very important, and whether she had menstruation at the time of the crime, yes or no, and whether she is having menstruation at the time of examination, we have to mention yes or no. And was the survivor pregnant at the time of incident, that also has to be mentioned. And if yes, then duration of pregnancy in weeks has to be documented. And any contraception used, yes or no, and if yes, which method was used, and what is the vaccination status as regards tetanus or hepatitis B, that has to be mentioned. And then comes the date or history of sexual violence, whether date of incident being reported, time of incident, location, what is the duration, estimated duration, whether it has been reported during the first 7 days or 1 week to 2 months or between 2 to 6 months or 6 months. And then episode was one or multiple or chronic, if we call it, if it's more than 6 months, and whether known or unknown. If known, the number of assailants, name, and sex of the assailants in approximate age, and if known, relationship to the survivor, and description of the incident in the words of the narrator. And narrator of the incident could be survivor herself or informant, and if informant, then we must specify the name and relationship to the survivor. And if required for any other extra information, we should add extra page and mention all that has been described to us. And then comes the type of physical violence used, if any. So the violence, physical violence could be whether she was hit with hand, fist, blunt object, sharp object, or by biting or pinching or by violent shaking or any other kind of violence. And also if she was burned with or kicked, pulled hair, banged head, or any dragging was done to her. And then comes emotional abuse, whether emotional abuse or violence, like by insulting, cursing, violating, terrorizing, or use of any restraints, or any threats, or use of any weapons or objects. And any verbal threats like threat of killing or hurting survivor or any other person survivor is interested in, or use of photographs or blackmailing. And then also either lured by any sweets, chocolates, money, job, alcohol, drinks, drugs, etc. or any other thing which the survivor has to tell. This has to be mentioned. And then comes any history of alcohol or drug intoxication, whether she was done during the time of incident and whether she was sleeping or unconscious at the time of incident. And also if the survivor has left any marks of injuries on the assailants, those details must be taken because they will really help in confirming. And then details regarding the sexual violence, oral sex by assailant. So we have to mention yes, no, or don't know. Any forced masturbation of self by survivor, again mention either of three things, yes, no, or don't know. And then forced masturbation of assailant by survivor or forced manipulation of genitals, mention again yes, no, or don't know. And then exhibitionism, that is perpetrator displaying genitals, even that has to be noted. Any ejaculation which occurred outside body orifice, that is outside vagina, anus, mouth, urethra, this has to be again mentioned in these ways. And if yes, where on body, and any condom used, and if condom used, what is the status of condom? Is it still there? Lubricant used? And if yes, which kind of lubricant? And if any object used, describe the object, because all these are going to carry great evidence. And then post-incident details, which is very, very important, that after the incident, the survivor has changed clothes or has changed the undergarments or has cleaned or washed her clothes or cleaned or washed her undergarments or has taken bath after the incident or has done douching or has passed urine or passed stools or has done rinsing of mouth or brushing or vomiting. Circle any of all as appropriate, because all these are going to help us about the evidence. And also whether she knows about it or no or don't know, this has to be again documented. And what is the time since this incident and any other remarks she wants to tell. And then history of vaginal, anal, oral bleeding or discharge prior to the incidents of this violence. And also same thing since the incident of sexual violence, or any history of painful urination, any painful defecation, fissures, abdominal pain, or pain in genitals or any other part since the incident of sexual violence. And then comes the general physical examination. You have to take height in centimeters, weight in kilograms, general build, gait, pulse rate, all these vital signs you have to take, and any other disability or deformity. And then examination of injuries on the body is very, very important. It can range from complete absence of injury, which frequently happens, and it could be some injuries also. So what kind of injuries? Like bruises, nail abrasion, teeth bites, cuts, lacerations, fracture, tenderness, boils or burns, and where on the body? Scalp, face, neck, shoulders, breast, wrist, forearms, medial aspect of upper arms, thighs, and buttocks. And then what kind, how do they look like, their size, the shape, color, swelling, signs of healing, are they fresh or they look old, simple or grievous, and their dimensions also, the size. So they all have to be documented. And then external genitalia, we have to record the findings on labia majora, minora, urethral meatus and vestibule, pusae and introitus, the perineum and hymen. And per speculum findings, if performed, or per vaginal findings, if performed, you have to record the reasons for these. Anus and rectum bleeding, tear, discharge, edema, tenderness, oral cavity bleeding, discharge, tear, edema, tenderness, all to be documented. But you must find it that now 2-finger test or the per vaginal examination test is banned. It has been banned by the Supreme Court of India ever since 2013. So this should never be done, because that is now banned and it does not help also. And systemic examination, again, we have to look for the central nervous system, cardiovascular, respiratory, and the abdominal. And then comes the very important part, evidence collection or the sample collection, to obtain confirmation of allegations, whatever we saw in the history and the examination, then to establish the link between the victim and the sign, and also to establish the link between the victim and the assailant. So every contact leaves a trace. So here comes the very, very important evidence collection.
Ma'am, request from the organizers to wind up. They have to start a second program at 4 o'clock. We're already 15 minutes late now. Sorry.
Right. So evidence collection, sample collection, you have to maintain the chain of evidence and identify specimen and label the specimen, sign the label, and record the disposal of the specimen. So all these things, some collection we have to do in the hospital itself. So hospital laboratory tests, as you all know, blood for HIV, VDRL, urine test for pregnancy, all can be done there. But at the forensic laboratory, the debris collection, paper, clothing evidence were available. So they all have to be packed in separate paper bags after air drying and sent to the authorities. So all these, as you can see in the slide, you have to take these samples, which are very important. The swabs from the stains on body, the scalp hair, head hair, nail scraping, oral swab, blood group for grouping, for DNA analysis, especially urine for drug testing, and any other if we have tampons, sanitary napkins, everything they have to be taken, and if not taken, the reason for not collecting have to be mentioned. So again, for genital and anal evidence, matted pubic hair combing, cutting of pubic hair, 2 vulval swabs for semen and DNA, and for 2 vaginal swabs for the same, and 2 anal swabs, and vaginal smear for semen examination, urethral swabs. So if not collected, again, you have to give the reasons. So then you give the provisional medical opinion after this. So these are the findings, and this is a provisional finding, because ultimately you have to wait for the results and then you give your final medical opinion. So after this, you give treatment prescribed, as we all know, for the STI prevention, emergency contraception, wound treatment, tetanus prophylaxis, hepatitis vaccination, and post-exposure prophylaxis of HIV, counseling, and others. So everything has to be documented, whether you did or not. And then the date and completion of examination, this has to be mentioned, the name of the doctor, the signature, as well as the seal has to be done. And final opinion comes after the lab reports, where you have to tell, ultimately after seeing the reports, that whether there's evidence of recent sexual intercourse or remote, or recent penetration, or evidence of remote penetration, or evidence of recent sexual intercourse, or evidence of remote sexual assault. Or there is no evidence of vaginal penetration, but you always say that possibility cannot be ruled out. You can just not say that nothing was, no evidence. And also, if there is any evidence of recent or oral or anal intercourse, or remote or oral anal intercourse, or any evidence of recent or oral anal penetration. And no evidence, again, we can just mention, but possibility cannot be ruled out. Every time you have to mention that way. And then findings in support of above opinion, taking in account to history, examination, and finding the all lab reports. You have to put the identification marks, so many hours or days after the incident. I am of the opinion that this is the report, final. And then the signatures and name of the examining doctor, and copy of the entire medical report must be given to the survivor or the victim free of cost immediately. And so in summary, you have to take, first of all, informed consent, and per vaginal examination or 2-finger test not to be done. Hymen and size of vagina, etc., never to be commented. And then you do injury documentation, sample collection, and give your final opinion. So following the components of comprehensive healthcare response to sexual violence, and they have to be carried out in all cases. So start with the consent, first aid has to be done before you take history, then examination. In examination, you have to do age estimation, physical, dental, radiological, and then you do evidence collection, where you put a seal, do a dry pack, you do documentation, ultimately hand over to police, and then you have to give treatment, as we just mentioned, and then discharge the patient and do a follow-up. So all these annexures are there for the whatever you should have in the kit, and what are the supplies for forensic evidence. So thank you so much for giving me the opportunity, and please do your pre-test and post-test. Thank you, sir. Thank you so much.
Thank you, Dr. Anita, for that very practical and very precise talk. I think it will go a long way to for the benefit of all those listening in today. because I think it has to be done in a very systematic and in a very precise manner to prevent any medico-legal controversies, as well as ensure that the best evidence is garnered for the accused, for the victim as well as the accused. Thank you, Pratik. On behalf of Komal and myself, we thank you and Parikshit for giving us this opportunity, and Dr. Shanta Kumari and Dr. Niranjan for having facilitated this session to be organized by Foxy and MOGS.
Thank you. I would like to propose the formal vote of thanks. Of course, starting from all the office bearers of Foxy and MOGS, the President, Dr. Shanta Kumari, Secretary General, Dr. Madhuri Patel, the MOGS President, Dr. Niranjan Chavan, and Dr. Rajendra Sangpal, all the wonderful faculty who spent their afternoon with us today, and the chairpersons who moderated and conducted the sessions. On behalf of Pratik and myself, we thank you all very much. Thanks to Mr. Ajay Bhardwaj and his team, and to all the people who actually created the PowerPoints also, which the faculty has incorporated and used in today's presentation. So with that, we call it a wrap for today. And hi, Kiran. Hi.
Yes. Just a reminder for the post which is posted.
Yes, I was just going to say that. I would request everybody to please complete the post test so that this entire process of training is deemed to be completed. Thank you very much and have a good evening.
Thank you. Thank you so much.
Thank you.
All of us. Thank you.